Okay, and welcome to the Davies Use Case webinar being presented by University of North Carolina Healthcare on empowering providers with data to affect behavior and reduce percutaneous coronary intervention costs. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support, best practice guidance, access to clinical data to analyze progress, and information and technology enable care delivery. Information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The HIMSS Davies Award-winning use cases have been peer-reviewed to validate sustainable and improve patient and business outcomes resulting from healthcare information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from UNC Healthcare, Lauren Onken, Dr. Joel Schneider, and Sean McDonald. Lauren and Dr. Schneider and Sean, I will turn the presentation over to you, and you can begin when you're ready. Thank you for joining us today.
Thank you for allowing us to present at the HIMSS Davies Enterprise Award for our case study, Empowering Providers with Data to Affect Behavior and Reduce Percutaneous Coronary Intervention, or PCI, costs. We are UNC Healthcare, leveraging IT to improve patient outcomes. My name is Lauren Onken, and I am the Executive Director of the UNC Healthcare System Heart and Vascular Service Line. With me today is Dr. Joel Schneider, an interventional cardiologist with UNC REX, co-chair of the System Quality Outcomes and Value Committee, as well as co-chair of the System Training Committee. Sean McDonald is also with us today. He is the ISD Enterprise Architect. Dr. Joseph Rossi is not able to be with us today, but he is an interventional cardiologist with UNC Medical Center and also a co-chair of the System Quality Outcome and Value Committee. I would like to take a moment and also acknowledge Dr. Prashant Kaul, now with Piedmont Heart Institute in Georgia, and Carol Lewis, the Associate Director of Innovation and Healthcare System Transformation, who were both instrumental in turning the concept into a reality.
We first wanted to share with you just briefly UNC Healthcare System. The UNC Healthcare System is an integrated, not-for-profit healthcare system owned by the state of North Carolina and based in Chapel Hill, North Carolina. As a system, we provide comprehensive patient care and are very proud of our strong track records in the area of physician education and research. We've seen significant growth over the last 6 or so years, such as doubling net patient revenues, licensed bed and employee counts, and either doubling or tripling our utilization in areas such as surgeries, ED visits, and clinic visits. UNC Healthcare System is an 11-hospital system that spreads across the state of North Carolina. The size and spread serves a diverse set of patient populations with many types of hospitals and services. We have both managed and owned entities. We have locations in both urban and rural settings. We're made up of academic, community, and specialty hospitals. And we also have over 700 outpatient clinic locations providing both primary care and specialty services to our patients. UNC has been the recipient of many awards and recognitions, including HIMSS Stage 7, MRAM, and OMRAM, and AMAM certifications.
We chose as one of our case studies to look at the cost of percutaneous coronary intervention and specifically the pharmaceutical costs associated with that procedure. we know that pharmaceutical costs were rising across the country and impacting patient care. Two studies were performed with the American Hospital Association and the Federation of American Hospitals to look at the cost of pharmaceuticals. And what was found is that between 2013 and 2015, there was a 23% increase in the cost of pharmaceuticals. And 90% of these hospitals indicated that these price increases had a moderate or severe effect on their ability to manage costs. This challenged providers really to limit their choices in medication, and also it compromised their ability to offer value-based care. The case study involves percutaneous coronary intervention. This is, to many lay people, placing a coronary stent. Here's a typical case presentation. A 57-year-old man presents to an emergency room having crushing chest pain. He is diaphoretic and restless with a low blood pressure at 90/69 and a heart rate of 110. This would indicate cardiogenic shock. An EKG showed ST elevation in the anterior lead. The diagnosis was an ST segment elevation MI, or acute heart attack. The management of this patient would require emergency intervention in the cardiac catheterization laboratory. The interventional cardiologist would detect a closed artery, as we see in A, and then perform a procedure which would open that artery and place a coronary stent to maintain flow in that major blood vessel, the left anterior descending, which you see in the figure B. To perform this procedure, one needs to choose an anticoagulant, a blood thinner. Two blood thinners are available to the interventional cardiologist. One is Bivalirudin, and the other is Heparin. Bivalirudin is 300 times more costly than Heparin. In 2008, the New England Journal of Medicine published a study called Horizons Acute MI, which suggested that Bivalirudin decreased bleeding and possibly improved survival of patients who underwent coronary stenting or PCI. As a result, between 2008 and 2013, there was a nationwide increase in the use of Bivalirudin. But during this period of time, two different things happened that changed the idea that maybe Bivalirudin was not any better than Heparin. One was a switch to transradial coronary intervention, that is using, instead of a femoral approach, a transradial approach, which in and of itself would reduce the bleeding risk, one of the major advantages of Bivalirudin. And also there were some sporadic cases of stents clotting with the use of Bivalirudin compared to Heparin. In a subsequent study in 2014 called PPCI, which challenged the use of Bivalirudin, actually found that the incidence of major ischemic events, that is clotting of the stents or MI resulting from these procedures, was no different, and there was no increase in bleeding. And importantly, this study showed that Bivalirudin was 300 times more expensive than Heparin. So in this single center institution that performed around 1,000 PCIs, it was savings of 500,000 pounds, or in US dollars, $640,000 in a year's time. When we looked at our cases, what we found at both the University of North Carolina Medical Center and UNC REX, the two largest hospitals that perform PCI, that over 88% of the cases at the medical center chose Bivalirudin, and over 75% of the cases at UNC REX. And so at a cost of 300 times that of Heparin and questionable value in a high utilization situation, we thought this would be an ideal project to try to make meaningful change.
Thank you, Dr. Snyder. Over the next 7 slides, I will walk you through the design and implementation of the initiative to empower providers with data to affect physician behavior and reduce percutaneous coronary intervention costs. This will include a high-level overview of the timeline, as well as specifics regarding the process required to develop the dashboard. Beginning with a single entity pilot and concluding with a robust multi-entity dashboard, the journey to reduce pharmaceutical costs while maintaining or improving outcomes for PCI patients took approximately 2 years. After the HEAT PPCI study results were presented at the ACC 2014 scientific sessions, interventional cardiologists at UNC Medical Center began a Heparin-first pilot in the summer of the same year. The pilot lasted 8 months, though the preliminary results were positive and quickly shared with UNC REX. In the spring of 2015, UNC Medical Center determined that in cath labs with high rates of access through the radial as opposed to the femoral artery, it is safe to implement a Heparin-first strategy during PCI. With multiple entities interested in the new approach, a multidisciplinary team formalized and championed the need for one centralized dashboard to capture cost and quality metrics. Notably, this involved the incorporation of external data from the CAF PCI registry, part of the American College of Cardiology suite of cardiovascular registries, also known as NCDR, or the National Cardiovascular Data Registry. To put this amount of information in perspective, the CAF PCI registry captures 14 pages of information for each patient that has a PCI. With quality and cost data in hand and a recommendation for a system solution, the team presented the value proposition to leadership and received approval for continued support to complete the dashboard. In the spring of 2016, the dashboard was ready to demo. A key element to the success of this initiative was and continues to be the multidisciplinary team of subject matter experts. The core committee initially included an interventional cardiologist from both UNC Medical Center and UNC REX, a champion from the UNC Center for Innovation, operational leaders, and members of both the strategic planning and pharmacy departments. This team outlined 4 major areas of opportunity, including reducing care variation, improving quality metrics, decreasing direct costs, and improving operational efficiency. With committed team members, research data, and institutional data in hand, the team proceeded with the work to implement a Heparin-first approach to PCI. This team also identified and addressed opportunities related to supplies. However, for purposes of this case study, we will focus solely on the reduction in bivalirudin usage. In July of 2015, the UNC healthcare system introduced a formalized heart and vascular service line and committee structure. This can be seen on the right-hand portion of the slide. A Quality Outcomes and Value Committee was introduced and co-led by the interventional cardiologist leading the PCI effort. The QOV committee work continues today, and additional subcommittees focused on minimizing care variation, decreasing costs, and improving quality have been developed. The PCI team is now a subcommittee of the QOV committee and has set the stage for both a broader scope of work for PCI as well as work with other heart and vascular subspecialties. The DMAIC improvement cycle was used and was well suited for this initiative. The first step required the team to prioritize and be specific about the issue that it wanted to address. There are many variables to be considered for PCI patients. However, the team narrowed the scope of this work specifically to opportunities during the PCI procedure. Because of the results of national data and the fact that bivalirudin was known to be expensive, the scope was narrowed even further, and the focus area became the usage of bivalirudin during PCI. The second step of the improvement cycle involved the development of a dashboard that could report various key metrics. It also involved the measurement of cost data and the comparison of it to internal systems such as purchasing and inventory management to ensure accuracy. The analyze phase was especially critical as the team needed to demonstrate that the dashboard not only centralized data, but it also provided additional functionality and insight. For example, the dashboard provided drill-down capabilities that allowed the team to ultimately identify a small group of outliers who had not yet reduced bivalirudin usage, despite the overall practice numbers showing a decrease. After the dashboard was rigorously tested and retested, the fourth phase began. The team sought improvement in terms of decreasing the usage of bivalirudin during PCI through data transparency. physicians were shown their own data as well as the data of their peers, and were invited to participate in one-on-one discussions with the team's physician leadership for more detailed information about the initiative. The fifth and final phase, control, continues to this day. The dashboard is updated and reviewed monthly by the team, though the reporting of multiple metrics has enabled us to identify other areas of opportunity while monitoring those that are in maintenance mode. The development of the dashboard, primarily completed in the measure and analyze phases of the DMAIC improvement cycle, was complex and required a lot of time from the team. However, it was necessary to get it right before moving on to distributing the information to drive change. A standard 5-step approach to building a solution was used successfully. As previously mentioned, the team identified the need for a single dashboard that could centralize data from multiple internal and external sources, reveal performance, and be used across the system. With these goals in mind, requirements of the dashboard were developed. The team asked that the dashboard reflect the most recent, near real-time data and a visual layout that would support easy identification of opportunities as well as monitoring of initiatives underway. The middle step of the dashboard development, the build, required the team to first identify all of the source systems. All of the data was then mapped to the data model, which subsequently moved all of the information into the Carolina Data Warehouse for Health, also known as the CDWH. Once the data was all in, we needed to get it back out by building the reporting solution into business objects. Additionally, logic was built into the dashboard which pre-calculated values that were previously unavailable. Sean will touch on this a bit later. Draft dashboards were completed and then tested by validating data against submissions to the NCDR, as well as reports from the internal source systems. A period of time was spent iterating between the build and test phase, but this was necessary as the final step of dashboard development was sharing the tool with stakeholders to drive improvement. Over the next 2 slides, I will provide more detailed information about the build phase of dashboard development as it required substantial time and effort. We were not simply dealing with 2 systems that needed to be joined, rather there were multiple systems and one varied by entity. The information flowing into the CDWH and ultimately back out through business objects reporting included data from 2 different cardiology information systems used for procedure documentation, from the loss and inventory system, and from the pharmacy system. Putting all of this information together was needed for us to have a truly comprehensive understanding of PCI events. Once the team was comfortable with the identified data sources and the information that would be input, the attention was turned to the design of the output. Mock-ups were drawn and various discussions took place about the number of reports to publish, the prioritization of the metrics, the timeframes used, and so on. Other related design features were also decided, including the type of charts used for each metric, as well as the display of baselines, averages, and targets. The visual on the right-hand side of the slide is an actual representation of the dashboard that was produced and pulled data from early 2014. The order of the metrics in the dashboard has changed over time, but it otherwise looks very similar to the one that is still used today. Even with the results of the HEAT PPCI study and the successful pilot at UNC Medical Center, the team knew that may not be enough to change the minds of physicians who have practiced in a particular way for what could be many years. The dashboard needed to share all of our own practice and physician-level data to help shift their mindset. A few examples of this are as follows. First, physicians were given the cost of Bivalirudin in comparison to Heparin to bring awareness to the stark contrast. This was new and eye-opening information to many of the physicians, though appreciated as they are all aware of bundled payments and shifts to value-based care. Next, physicians had access to information about their peers' usage of Bivalirudin, and this transparency resulted in many of them not wanting to be seen as the outlier. They were also able to observe through NCDR measures that patient outcomes were maintained and or improved after switching from Bivalirudin to Heparin. And finally, the feature of the dashboard that was particularly useful in this initiative, as well as future initiatives, was the built-in calculations that essentially removed the actual and perceived differences in populations as well as case complexity by use of statistical clustering. Later in the presentation, we will discuss the actual value derived from the dashboard.
We built several key pieces of functionality into the dashboard to allow it to be used for a variety of purposes. Controls were entered so that users could filter and drill down into data to find specific opportunities. These allowed users to drill down to a specific location, specific provider, specific time frame to gain deeper insights into some of the information they were looking at. The top right of the dashboard summarizes the current filters that are applied, so you don't have to remember what selections were. And the dashboard is flexible and allows comparison between different locations, providers, and date ranges by bar graphs, and also by trended data over a certain time frame. We standardized all the data going into the dashboard for multiple systems into a single view for common reporting across all of the initiatives. And key measures on the front page of the dashboard provide ongoing monitoring, such as our initiative here for bivalirudin usage. The front page of the dashboard highlights metrics of importance for monitoring the overall health of the program and displays things like procedure volume, supply cost by categories, and procedure types. It's also used to highlight measures that the heart and vascular program is working to improve or are important for our current initiatives. We have a section dedicated to quality outcomes and registry metrics, and we continually monitor these areas for changes over the course of our initiatives. This information is made up of near real-time measures from our various clinical source systems, as well as abstracted information from registry submissions. The dashboard is shared and reviewed as a recurring agenda item at internal meetings with the heart and vascular leadership. Physicians receive unblinded dashboard results that show their performance compared to their peers and benchmark against goals and department averages. Cath lab staff also has access to blinded versions of the dashboard, which show individual performance without identifying the actual provider. The results were very well received. Dr. Schneider summarized our findings well here with a quote saying, "Doctors receive the information in an extremely positive fashion." One key to this was that after training, most doctors, and that's interventional cardiologists, work independently during cases and patient care with limited exposure to our partners. So being able to share practice patterns and understand cost and quality among peers results in a positive change in behavior. This strategy for visibility and access to information has been successful in many of our healthcare system initiatives, both past and present, including our meaningful use MIPS macro requirements and reporting of our internal organizational goals.
The major goal of this project was to influence a decrease in bivalirudin usage among the interventional cardiologists. And what we saw before and after this intervention was a 90% reduction in bivalirudin usage. You can see in this particular slide how this differed between the University of North Carolina Medical Center and UNC REX. This is an important feature of this study. What we found at UNC REX, which was made up of a small number of interventional cardiologists and met on a weekly basis, they were able to make an immediate decision to not use bivalirudin except in special cases and switch to a heparin-only strategy. But at UNC REX, it was over 20 interventionalists who met infrequently to discuss patient care matters and policy. And so that the adoption took time as compared to the medical center. What we found, however, is that after a year's worth of work and education, that the end result was similar between the medical center and Rex Hospital, and again, 90% reduction in bivalirudin usage. In this particular subset, we looked at 6 interventionalists that were slow to make the transition from bivalirudin to heparin. And what we found is that after we provided them with the dashboard and had an educational meeting so that they could learn from their peers, that shortly after this presentation, those interventionists also adopted a policy of heparin only. And so what this meant to the medical center was significant cost reduction. By switching from heparin, which would cost around $4.68 per case, whereas the cost for bivalirudin was over almost $750, there was a cost savings in just these 6 providers that were slow to change of $176,000 over the course of 2017. And if you generalize those savings for the year over the 2,800 cases performed at the medical center, the savings were $1.6 million. So this was a major cost saving for the institution. Of course, importantly, we wanted to assure that the quality and safety of making this change translated with patient care. And the 2 major issues of bivalirudin and heparin, and particularly choosing bivalirudin from the beginning, was that it reduced bleeding and that it reduced vascular complications. But as we can see here, between 2014 and 2017, there really was no significant change in bleeding events. Next slide. The second concern was, would there be a higher risk of stent thrombosis, that is clotting within the stent? And again here, over that same time period, we saw no change in the percent of patients that experienced in-stent thrombosis or clotting. And perhaps most importantly, when we observed the mortality, observed versus expected mortality ratio, a calculation that applies to each individual institution, we saw no change in mortality. So we felt that we could safely say that in addition to significant cost savings, that there was no change in the quality care that we offered our patients who required percutaneous coronary intervention or coronary stenting.
Okay. One point that we wanted to call out with the method that we used for this intervention is that we did it without the need to add additional disruptive alerts to providers. So UNC takes an education-first approach to changing provider behavior. We did this by introducing unblinded data to these providers so that we could show their actual performance, and they could use that to compare against their peers. And this, again, has been effective for many of our quality and utilization programs that we have. A couple of reasons for that. Providers are not always aware of the process that they have and that they're aware of their current progress or otherwise understand the numbers that they have in the background. So we hear things like providers didn't realize the practice recommendations changed for bivalirudin usage. It also drives information about sharing best practices between providers so that a conversation can occur for how one provider's usage may be different than another provider's usage. And we also know that providers care about their progress in comparison to their peers. So we've heard things from other initiatives like, I have to make sure to do this so that I can beat provider XYZ over the next month in our quality measures. This method also works best when providers know that leadership is interested in reviewing the same data and has this in front of them at regular meetings. UNC likes to use provider alerts only when it's a means of last resort. So if other preventative measures have failed or if adverse events warrant severe disruption.
We learned a lot during this initiative, and our use of the PCI dashboard continues today. A few of the reasons why are shown on the next slide, and I will briefly touch on each one. First, the dashboard is a tool that we review regularly. Once the team felt comfortable moving the bivalirudin reduction initiative into maintenance mode, we turned our focus to reducing variation and costs associated with supply. This information was also available to physicians and led to specific initiatives at both entities. The comprehensiveness of the dashboard lends itself to various opportunities that continue to be identified today. We also demonstrated the value of moving pilot data from one entity to another, ultimately leading to a partnership and a new level of transparency. This method will serve as a model for other value-added opportunities in the system service line. Next, the initiative resulted in significant change that was driven by data and an education-based approach. This was a well-received and effective method for influencing physicians to reduce bivalirudin usage, but feel confident that it would not adversely impact patient care or outcomes. We intend to use this approach in the future. Lastly, we are taking this work and scaling it to other heart and vascular procedures and system entities. From the beginning, the intent was for the dashboard solution to be nimble and repeatable. The stage is set for our value work to continue long into the future.
So we would like to thank our speakers from UNC Healthcare today for joining us and presenting their Davies use case. I want to remind our listeners where to go find this and more important Davies use case webinars. That information can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you for listening and have a good day.